of the increased signal intensity. Flare is not the signal from the CSF. So it's particularly helpful for the region of the brain that's just adjacent to the ventricle in the preventricular and cortical region. The DUI is the most sensitive sequence for imaging of the stroke. It can show the changes of the stroke within the minute of the onset of stroke. It is sensitive to detect the restriction of the diffusion of the water protons due to the imbalance caused by the cytotoxic edema. Normally, the water proton have the ability to diffuse extracellularly and lose signal. High intensity on DUI indicate restriction of the ability of the water proton to diffuse extracellularly. Here you can see on the left side a flare image showing the high signal intensity in the right middle cerebral artery territory and in the right basal ganglia, while in the DUI image you can see the exact extent of the infarct is involved the larger area that's appear on the flare image. Of course, the DUI image should always be interpreted together with the ADC map. ADC is not an MRI sequence, rather than it's acquired post. The first and the most important one is the chronic. It's called the T2 shine through. There appear high signal intensity on both DUI and T2 weighted image, but the difference, they also appear high signal intensity on the ADC. Also, acute hemorrhage can generate high signal on that resembling an infarct, but here is an acute left middle cerebral artery infarction. On the non-contrast CT scan, you can see the subtle loss of the gray-white matter differentiation in this territory. In the T2 weighted image, you can see the abnormality is more obvious in this region as there's increased signal intensity. On the flare image, even the abnormality is more obvious than the T2, and the DUI is the most and on the ADC map is appear at the area of the low attenuation, low signal intensity. Here is the T2 shine through artifact. We have these lesions that are hyper intense on the T2 weighted sequence. On DUI also they are hyper intense, but when we get the ADC map, they are also high signal intensity, indicate that they are due to the more chronic process rather than the acute infarction. The signal intensity on the MRI is also vary according to the age of the infarction. Hyperacutely, we have the primary abnormality of restricted diffusion. So on the flare, there may be normal, or on the T2 and flares, there may be normal or subtly hyperintense. The DUI is hyperintense, ADC is hypointense. In the acute infarction from 6 to 72 hours, there will be increasing of the vasogenic edema, and the mass effect is actually start to appear from the acute infarction. So the T2 and flare is showing the gray matter hyperintense, the DUI again hyperintense. In the early subacute infarctions, there will be starting of the blood flow to the affected brain by the collaterals. So there will be less restricted diffusion. But the mass effect is peak here is approximately 3 to 5 days. The T2 and flare is diffusely hyperintense, DUI is hyperintense, and ADC is starting to resolve. In the late subacute phase, from 5 days to the 2 weeks, the diffusion start to normalize. There will be gyrial enhancement, start to peak, and there will be resolution of the mass effect. So the T2 and flare is diffusely hyperintense, DUI is mildly bright here, starting to begin to normalize, and the ADC is isointense. In the chronic infarction, there will be cystic encephalomalacia and no more mass effect. The T2 and flare show diffusely hyperintense, the DUI is isointense, and ADC is hyperintense. We should notice that the peak mass effect and peak contrast enhancement is in the acute infarction is never happen in the same time. So whenever you have a lesion that show the peak mass effect and peak contrast enhancement, you should think about other pathological process, for example, the brain tumor, rather than the infarction. Here is the difference between T2 DUI and ADC in the case of the acute and subacute infarction. In the case of the acute, you see the T2 abnormality is relatively subtle at the mild increase of the signal intensity, while in the subacute, it is clearly show the high signal intensity. In both of them, DUI the low signal intensity region of the right cerebellar hemisphere. Here is the T2 signal in the case of the stroke, starting from initially maybe normal or subtle increase, starting to increase in the period of the 7 day, reaching the peak value. And it's about the early to late subacute phase. DUI is starting high and peak in the subacute phase again, but later start to decline. ADC in contrast, starting from the low value, starting from a low signal and starting to peak in the chronic infarction. The contrast enhancement. Actually, for contrast enhancement, we have what's called the rule of two. It is said that the contrast enhancement in infarction starting in the day 2, peak at the week 2, and start to resolve in the peak at the second week and start to resolve in the second ones. I couldn't get a clear picture of it actually. Here we can what I able to get. We have a stroke imaging from in this 8 hour 1 day and 1 week. Here you can see above row is the T1 weighted image, and here is the contrast enhanced image. In the above image, you can see there is gyrial swelling in this area on the left middle cerebral artery territory. Or the contrast enhanced image, you can see in the 8 hour and 1 day image, there is enhancement of the vessel across the area of the infarct, where in the 1 week, there is moderately enhanced cortical and subcortical area. This image is the DUI and ADC map to differentiate between the new and old infarct. On the FLAIR image, you can see the high signal intensity involving the post-frontal lobe infarct, as shown the low signal intensity center. So on the DUI, you can see that the left frontal lobe is so restricted on the diffusion, while there is no restriction on the diffusion on the right side. On the ADC, you can see this region is present with a low signal intensity, so it's indicated an acute infarction. Where we have high signal on the right side, it indicates that it is a chronic infarction. Hemorrhagic transformation is occurred due to the bleeding into the area of reperfused ischemic tissue, as seen within the first 2 weeks in up to 80% of the infarction, as seen most commonly in the basal ganglia and cortex. Here you can see an axial non-contrast enhanced CT scan of the patient with acute stroke. You can see the area of the low density in the left occipital lobe. In the subsequent days, the patient deteriorated, and re-examinations show this area of the high density in the region of the infarction. Also, there is mass effect of the left lateral ventricle. So this indicates the hemorrhagic transformation of the infarct. Again, you can see this area of the high density on the non-contrast CT indicate the hemorrhage is also involved the caudate, head of the caudate. On the coronal T1 weighted MRI, you can see this high signal intensity indicate hemorrhage. The MR perfusion weighted image, DUI is used for detecting of irreversibly infarcted tissue, while perfusion image is used to detect the area of reversible ischemia. The technique is by injection of the contrast to the patient, of gadolinium to the patient, and acquiring the echoplanar sequence. We should always interpret the perfusion MRI together with the DUI. If the regions show both perfusion and diffusion abnormality, it indicates that it is an irreversibly infarcted tissue, while the regions that show perfusion abnormality but no diffusion abnormality is indicate the ischemic penumbra. Here you can see that the DUI showing this region of restricted diffusion, while the perfusion MRI show the abnormality that is more larger than the one seen in the diffusion. So there is a mismatch between the perfusion and diffusion image. This indicates that the infarcted core will show both diffusion and perfusion abnormality is this region. And also this perfusion defect, but no
diffusion defects. The MR angio, it could be obtained by contrast-enhanced scan or by the time of light MRI without injection of the gadolinium. Here you can see a gradient recall echo image showing the blooming artifact in the right middle cerebral artery. It is same as the hyperdense middle cerebral artery on CT. On the corresponding MR angio, you can see the absence of the flow in this territory of the middle cerebral, in this branch of the middle cerebral artery. The watershed ischemia or border zone infarct is happening in the boundaries of the major vessel territories is due to the global hypoperfusion between the middle cerebral anterior cerebral artery or between the middle cerebral and posterior cerebral artery. It's usually uncommon in the posterior fossa and account for the 5 to 10% of the cases of the all infarction. It's tend to happen in the elderly patient who have a higher incidence of the aortic stenosis, hypotensive episodes, and microembolization. The watershed infarction is divided into two subtypes. We have cortical or external border zone infarct is seen between the branches of the anterior cerebral, middle cerebral, and posterior cerebral. They are seen as the parallel parafalcine strips in the subcortical area. Well, we have the deep internal border zone infarct. In addition to involving above arteries, it's also involving the perforating medullary lenticular striate recurrent artery of Hebner and anterior choroidal artery. To diagnose, we should have more than 3 lesions, each of them more than 3 millimeters in diameter. They are arranged in a linear fashion parallel to the lateral ventricle in the centrum semi-oval or coronary radiata. Here's an MR angio. You can see the severe occlusion of the right internal carotid artery just above the bifurcation here, or the left internal carotid artery. The axial MR imaging diffusion image show the area of the high signal intensity in the frontal and parietal lobes. They are arranged in a linear parallel fashion to the lateral ventricle, as is indicated the border zone or watershed ischemia. The top of basilar syndrome, also known as the rostral brainstem infarction, is seen when there is occlusion of the basilar artery, the tip of basilar artery. This results in the involvement of the infratentorial thalamic occipital infarction, occipital and cerebellar infarction. You can see here a DUI image showing the high signal intensity in the left thalami in the occipital lobe in a different patient, multiple infarction involving the posterior cerebral and superior cerebellar artery territories. Again, top of basilar artery syndrome involving the left thalami, occipital lobes, and both cerebellar hemisphere. So for imaging of acute stroke, answer is both of them has its advantage and disadvantage. While the CT has advantage of being available, of low cost, it is safe and relatively rapid, and high sensitivity for detecting hemorrhage, it has a disadvantage of using radiation, the poor image resolution for posterior fossa, and sometimes administration of the iodinated contrast media could be fatal in the patient with the chronic renal impairment. MRI has the advantage of high sensitivity for the stroke and stroke mimics. It has high sensitivity for detecting the cerebral perfusion and high resolution, while it has the disadvantage of patient tolerability, long acquisition time, low sensitivity for cerebral hemorrhage. This was about the large vessel thromboembolic disease. We have the small vessel ischemic stroke. Due to the arterial occlusion of the long penetrating arteries, the risk factor including age, hypertension, elevated hemoglobin, diabetes, smoking, and hyperlipidemia is affecting the periventricular and deep white matter, basal ganglia, and ventral pons. Radiologically, acute lacunar infarct appear as a rounded area with hazy outline, which may be fluctuate in size, while mature lacunar infarct appear as sharply delineated, and it is usually cavity-like. You can see here, small vessel disease, axial flare show high signal intensity, which indicates the small vessel disease is a periventricular region. We have this area of the mature lacunar infarction. The DUI image show this area to be restricted, to show restricted diffusion, while the mature one show no restriction of the diffusion.
We have moya disease. It's important to mention because it is the most common, it accounts for 30% of the cerebral ischemia in pediatric population. It is dilated collateral vessels secondary to the progressive stenosis of the terminal branch of the internal carotid and proximal intracranial segments. The etiology is idiopathic. However, it may be associated with the sickle cell disease, neurofibromatosis, cranial irradiation, Down syndrome, HIV, and tuberculous meningitis. It primarily involves supraclinoid internal carotid artery, proximal anterior cerebral and middle cerebral artery, only occasionally affect the posterior circulation. Moya is a Japanese word used which means the puff of smoke that describe the angiographic appearance of the collateral vessel. Here you can see the puff of smoke sign in moya disease, which is the hypertrophy, abnormal hypertrophy of the collateral vessel. You can also see the stenosis of the both M1 and A1 segments of the internal carotid artery. This image belongs to a patient with a sickle cell disease and developed moya syndrome. There is extensive deep frontal periventricular watershed infarction. Here you can see the collateral vessel, and there is, if you compare the size of the right and left, you can see there is a decrease in the size of the right middle cerebral artery. On the MR image, you can see the decreased flow to the middle cerebral, right middle cerebral, and right anterior cerebral artery. There is also a small aneurysm of the right anterior cerebral artery. The global cerebral hypoperfusion syndrome is due to the severe hypotension or impaired blood oxygenation. It can result in the watershed infarction. It could be due to the anoxia, due to the CO2 poisoning. This could be quite tricky because the changes is usually bilateral and it is symmetrical. Here you can see the imaging for patients with global hypoperfusion, acute watershed ischemia that affecting brain is a bilateral and symmetrical fashion. You can see as area of the diffuse brain swelling on the FLAIR image. The second image again begin to the patient who developed a hypoxic ischemic brain insult after self-hanging. The third one is the Dewey image, showed the diffuse high signal intensity in the gray matter. Actually, this one maybe seems normal to you, but you should always keep in mind that that in Dewey image we cannot see this degree of gray and white matter differentiation. So this should alert you about the diagnosis of a global hypoperfusion syndrome. Lastly, cerebral venous thrombosis. It's an infection due to the venous occlusion. It's not confined to the arterial territory. It's often hemorrhagic and multifocal. The superior sagittal sinus is most commonly affected. And the risk factor including the trauma, infection, hypercoagulable disorders, smoking, and vasculitis. The area of the brain that is affected by the venous infection is vary according to which sinus is involved. For example, superior sagittal sinus occlusion affect the frontal lobes. The transverse sinus and vein of Labe affect the temporal lobe. The straight sinus affect the thalamus. Radiological feature, I will show on the images. Here, the distribution according to the involvement of the vein. If the internal cerebral vein is involved, we have the infarction in the basal ganglia and thalami. If the vein of Labe is involved, we have the infarction of the temporal lobes, while thrombosis of the superior sagittal sinus lead to the bilateral parasagittal frontal lobe involvement. On the non-contrast CT scan, we have what's called the dense clot sign. Here, a non-contrast enhanced axial CT session, you can see this hyperdense region inside the superior sagittal sinus, which indicates the acute thrombus. Here you can see the dense clot sign inside the cortical vessel. It is actually a linear or cord-like, sometimes referred as a cord sign. On contrast enhanced CT scan, you will see the empty delta sign. Normally there should be filling on the superior sagittal sinus on contrast enhanced scan, while here you can see filling defect, which indicate the empty delta sign. On the MRI, you see the absence of the normal flow void. Normally the venous sinus should appear flow void on the MRI image. Here you can see a normal right, but absence of the flow void in the left sigmoid and the internal jugular vein. Again, you can see absence of the flow void in the internal cerebral straight sinus, and the right transverse venous sinus indicate the venous thrombosis. Here is an venous infarction due to the superior sagittal sinus thrombosis involving the bilateral frontal lobes. Here you can see, and the obstruction of the thrombosis of vein of Leppe. You can see this area of the hypodensity in the left temporal lobe, and also there is linear. If you can see, there is linear hyperdense region indicates the hemorrhage. So this is a hemorrhagic infarction. What is the trick to diagnosis here is the hyperdense region of the left transverse sinus, which indicated the thrombosis inside the left transverse sinus. Again, this image belongs to the patient who developed the deep vein thrombosis and cerebral infarction. You can see there is edema, swelling of the left of the internal cerebral vein. And on the venogram, you can see the presence of the superficial venous system, superior sagittal sinus, but absence of the deep cerebral venous system. The treatment for the stroke, including either IV thrombolysis or embolectomy. The thrombolysis, it has a criteria to be given. The most important one is the hemorrhage is being excluded, less than 4.5 hours from the onset, infarction of less than 1/3 of the middle cerebral artery territory, and the patient should be less than 18 years old. For the embolectomy, you have a number of the techniques, as including the endovascular mechanical embolectomy, aspiration embolectomy, or sometimes surgical embolectomy. And thank you.
شكرا جزيلا.